Welcome back. We are on Unit 1, Mod 2, and today we are going to be looking at the history of trauma and PTSD. There will be some things for you to do after you watch this video and look through the PowerPoint. I am going to invite you to another journal in which you will answer some questions just about yourself and your own history and just try to begin to understand trauma from a very experiential level. And I think that will be beneficial to all of us. We can kind of personalize these things and begin to understand them. Now, again, please remember, we're not doing therapy on each other, but rather we are just kind of exploring these ideas through the person we know best, ourselves. So, history of trauma and PTSD, Unit 1, Mod 2. When we think about trauma and trauma studies, we can start in the late 19th century with maybe the father of this line of inquiry, Jean-Martin Charcot. Charcot was focused on the idea of hysteria. Hysteria, as you read in the Herman text, was very commonly understood at the time. I love this quote that one historian explained hysteria as a dramatic medical metaphor for everything that men found mysterious or unmanageable in the opposite sex. And so hysteria was this encompassing word to try to properly diagnose the incoherent and incomprehensible that men saw in women. Sexist, I know, but that's kind of where it came out of. So Charcot focused on symptoms of hysteria that resembled neurological damage, things like motor paralysis, sensory loss, convulsions, amnesia, those types of things. And through research and clinical studies, it was able to demonstrate that those symptoms were psychological, because they could be artificially induced and relieved, treated through the use of hypnosis. So two of Charcot's disciples, those that learned from him, were Pierre Janet and Sigmund Freud, a name that you've probably heard. While they both studied hysteria and came to some similar conclusions, they also had some observations and beliefs about hysteria that stood in stark contrast to each other. So for Janet, hysteria was defined as a capacity for dissociation, which was a sign of psychological weakness, whereas Freud thought hysteria could be found among people of the clearest intellect, people who had strong will and great character and high critical powers. So for Janet, hysterics were psychologically weak. For Freud, hysteria could be found in anyone. Janet said that his hysteria patients were governed by their subconscious fixed ideas, while Freud said, no, hysteria patients are governed mainly by reminiscences, remembering past experience, those types of things. And so this line of hysteria thought was explored in the late 19th century. Ultimately, it's not that this line of thought went nowhere, but this line of thought was was very limited until the 20th century, when hysteria began to be looked at more in the sense of the word that we call trauma. And so in the 20th century, especially through studies on war and biology, and then later on looking at child outcomes and parenting, and especially in the late 20th century, looking at the experiences of women, we began to uncover this idea of trauma. So what we know from these early studies, World War I and World War II veterans, they had a greater family history of psychopathology among families of veterans who were diagnosed with war neuroses, which would later be more explored and refined and begin to be understood more in terms of post-traumatic stress. There was evidence for a biological risk factor to PTSD. There was a higher concordance of rates of PTSD among monozygotic versus dizygotic twins that were exposed to trauma. Mono being one zygote, di two or multiple. And then Huda even put forth this idea that low cortisol levels among adult children of Holocaust survivors who have PTSD and whose parents also have PTSD was evident. So there's a biological piece to this as well. Speaking of Holocaust survivors, Holocaust research compared adult children of Holocaust survivors with and without PTSD diagnoses to children whose parents were not exposed to the Holocaust. And what was found was that 59% of the entire sample reported lifetime prevalence of at least one Axis 1 psychiatric disorder. The common diagnosis of the offspring, PTSD, mood disorders, and other types of disorders and phobias. Subsequent analysis showed that parental PTSD significantly predicted offspring PTSD. Parental Holocaust exposure, but no PTSD, significantly predicted offspring depression. Well, what does that tell us? It tells us that there is something systemic, right? There's something happening, perhaps biologically, with transference of trauma. It's not just the person who experienced trauma, but that there may be something in our very genes that passes on trauma or passes on the ability to experience trauma in similar ways. Child outcomes, when we studied Vietnam veterans and their children, there were more dysfunctional scores in children who had an abusive father. We know that child's behavior problems were significantly associated with a history of abuse as a child, combat exposure, not being married, low income family violence, family maladjustment, and the severity of the father's PTSD symptoms. And so just studying children, we began to understand even more this idea of trauma and its effects, not just on individuals, but on systems. And we looked at parenting research. Lauterbach showed a study where 591 parents with PTSD, combat and non-combat related, were analyzed, and there was poor parent-child relationship associated with those parents who had more children, who were fathers, who were in poverty, and who had high avoidance rates, parental numbing, and re-experiencing significantly related to parent-child aggression. And parents with PTSD reported poor parent-child relationships. And so we see this idea of trauma being familial, right? And then there was a focus on women, especially in the later parts of the 20th century, and their uh, their own trauma and PTSD, not understood now as a war disorder, but as a trauma disorder. The first speak out on rape happened in the early 70s. Rape trauma syndrome was coined in 73, the battered woman in 79, and a look at father-daughter incest by Herman in 1981, all began to show that women were being victimized, and this victimization was traumatic and very similar to the outcomes of war veterans. And so we began to understand PTSD in a different light. So in the 21st century, really we began to kind of take all of those thoughts from the previous century and really in the last 20 to 25 years, really begin to look at trauma from a systemic focus. And so I want you to think about this as kind of re-experiencing avoidance and arousal of the individual and its impact on the family system. We really have begun to understand that trauma doesn't just affect the individual, it affects the system. And so even in relationship within the system, we see feelings of detachment or estrangement from others, a restricted range of affect and reduced ability to even express emotion, irritability and outbursts of anger, isolation and withdrawal. All of these are relational types of outcome that are experienced post-trauma, right? So it's not just the individual, it's the system that they are a part of that are feeling those effects. And even coined a term called secondary trauma, which we'll talk more about later in this course. But this idea that that the partner, the caregiver, others in close relationship might also be traumatized because of the trauma that the victim themselves faced, right? And so there might be a vicarious traumatization or a transmission of that trauma, or in some cases, the caregiver experiences things like compassion fatigue and burnout when trying to deal and help the victim, primary victim, deal with the experience of the trauma in the first place. We also have seen a great advancement in our understanding of post-traumatic stress disorder, PTSD. I'm not going to read through all of this with you, but I do want you to access that PowerPoint and just kind of see where we are. This is from the DSM-V, the Diagnostic Statistic Manual. This is the Bible of disorders, right? And diagnoses and how we diagnose things and when we diagnose things. And PTSD is now included in a new category called trauma and stress-related disorders, which kind of indicates that maybe this is part of a trauma spectrum, the way that we experience, respond to, deal with, cope with, and move past trauma or through trauma is all part of a spectrum, perhaps. And I want you to see that all of the following criteria are required for a PTSD diagnosis. And again, we're not going to read through all of these, but I want you to see that there are several criteria, A through H. And in each of these criteria A, a stressor, one of those things is required. And criterion B, intrusion symptoms, one of those is required. And criterion C, avoidance, one of those is required. Criterion D, negative alterations in cognitions and mood, two of those are required. Criterion E, alterations in arousal and activity. Criterion F, G, and H, duration, symptoms lasting for more than a month. Functional significance, symptoms create distress or functional impairment. Exclusion, symptoms are not due to medication, substance use, or other illness. And then specifications for when these criterion may or may not occur. All of that to say that we have come a long way in our understanding of post-traumatic stress and how we diagnose it, in turn how we are going to deal with and treat that in patients. We've also seen in this century a continued focus on war, thinking about Iraq and thinking about terrorism post 9/11 and traumatic stress dealing with events that seemingly are out of our individual control. We've seen a greater focus on mental health this century, and we're understanding more about trauma in individual lives and day-to-day trauma and how that affects us as people and as family members. We've seen a continued focus on child abuse and child welfare, and an increased focus on sex trafficking and child pornography and those types of traumatic events. We've seen an increased focus or a continued focus on women and ending violence against women. We've seen a increased focus, maybe a new focus on a movement towards equality in our society, so that our own social systems aren't traumatizing us because of our gender or our ethnicity or our ability, or the list goes on and on and on. And so there's still so much out there to learn and to focus on about trauma and PTSD. And so I hope that you will find some of these things engaging and interesting, and want to continue to study those things. All right, what I would like you to do next is to go to journal number 2. Pretty simple today, some questions for you, do some introspection and fill out, and we will be back for Unit 1, Mod 3 in just a while.